Great. Well, thank you very much. I want to give a shout out to the program committee for inviting me to attend, and congratulate you on the conference so far. I'm here to talk about physician entrepreneurship, and I think it's relevant given the theme of this conference, which is innovation and building innovation ecosystems. So far we've heard about the challenges, the opportunities, kind of the mandate, aging population, dropping birth rate, limited resources, et cetera, and I thought I would share some experiences with you and fundamentally deliver the message that for too long it's been my experience that the two most important elements of the innovation, the healthcare innovation supply chain, have been ignored, and that is the doctor and the patient. And top-down innovation ecosystems, by and large, have a limited lifespan. And it's been my observation that what we're seeing now are community-based, participative, bottom-up innovation networks. And I think that for Korea and for other nations in the world trying to cope with similar problems, like the United States and like some areas where I've worked, that the more you can engage participatory communities and innovation networks, the more successful you will be. And I'll give you some examples of how we've approached this problem. Maybe we can Okay, so in the way of disclosure, I do a fair amount of work with early seed stage companies, startups, private equity, investment, angel networks, that sort of thing. So these are the companies that I either own or have helped create or have a financial interest. And a lot of these companies, as you can see, are either biomedical or health. Biomedical as defined by medtech or biotech, health companies as digital health, process, performance, systems innovation, that kind of thing. So I just want to give this disclosure to let you know where I'm coming from. I'm from the University of Colorado. For those of you who are not familiar with Colorado, welcome. From Colorado, we're a state in the middle of the United States. We're about 5 million people. You're probably familiar with our landscape in terms of skiing, Aspen, Vail, major ski areas. Really a beautiful place. And what's more important for this conference is that we've embarked on a fairly ambitious innovation ecosystem build-out that I think in some instances serves as a model for the United States, if not other places in the world, that are trying to advance biomedical and health innovation. And you're certainly welcome, and I encourage a collaboration. I had a great talk earlier this morning with several physician entrepreneurs who are interested in possibly collaborating with us. So if any of you are interested in working with us in terms of service providers or investment or technology development, particularly in digital health, I encourage your participation. The message that I want to give to you is that physician entrepreneurship, and I'll define that in a minute, continues to grow around the world. The problems that we're discussing today are certainly not unique to Korea. They're not unique to the United States. They're not unique to the United Kingdom. But in fact, most industrialized countries in the world, and certainly emerging nations, are dealing with how to deliver healthcare with limited resources and how to jumpstart innovation and entrepreneurship in their countries for a number of reasons, not the least of which is to raise the standard of living and make their countries more globally competitive. I think Korea is in that category, and certainly almost every state in the United States is trying to promote themselves in one way or another as an innovation hub. But the bottom line is that physicians are finally becoming empowered to participate in innovation, and I believe it's in your best interest to engage those people, certainly in Seoul, if not in Korea, as part of a plan to diversify the industry or to further move it, what you've already admirably done. In my view, physician entrepreneurship is driven by three basic innovation, internal and external factors. The the external factors have to do with necessity. The fact of the matter is that healthcare is in crisis in some countries, and unless we innovate, we're going to have a very difficult time in the future, as you heard, with aging population and all the other things that we've mentioned. But more fundamentally, I believe that there's an entrepreneurial spirit in most people, in most countries in the free world, and in fact, most physicians, maybe more so in some than others, but want to fundamentally help patients. I mean, that's why they went into healthcare, and this applies to other healthcare professionals. So I believe that the entrepreneurial spirit in physicians, in a lot of respects, has been stifled, and I'll share some information about how we're addressing that. That being said, there are persistent barriers to widespread growth and development of physician innovation, and we'll go through some of those things. A lot of it has to do with culture. A lot of it has to do with a lack of leadership. A lot of it has to do with how physicians are chosen and educated in medical schools in both Korea and in the United States, and barriers to and presented by the ecosystem to physicians who want to innovate or collaborate with other members. And finally, I believe and have observed that top-down, cluster-driven, command and control innovation ecosystems have a limited lifespan. And those companies or those industries or those governments that try to impose rigid innovation structure eventually run into some barriers that leads to failure. In addition, we've seen that with the advent of cheap internet and mobile communications, that bottom-up, decentralized, participatory collaborative innovation networks are becoming more and more common, and the Society of Physician Entrepreneurs is an example I'll give you that basically demonstrates that in order for an ecosystem to really generate clout, that there needs to be a bottom-up and top-down balance, and more people need to participate. I would also say that it's arguable whether healthcare can be fixed from inside. And by that I mean that healthcare workers, by and large, including doctors, do not have an entrepreneurial mindset. In fact, it's my observation that about 1% of doctors have an entrepreneurial mindset, and the same applies for engineers, the same applies for graduate students and other healthcare professionals. So the real issue is how do you identify people or inculcate an entrepreneurial mindset and create an innovation ecosystem that allows them to thrive. The cheap internet communications, mobile technology, e-health, and all the things that you're very good at have facilitated the development of these sorts of things, and I'll give you some examples. So what is physician entrepreneurship? There's lots of definitions, but the one that I usually allude to is the participation of doctors in the pursuit of biomedical and health opportunity. So number one, it's the pursuit of opportunity. Number two, you're doing it with scarce or uncontrolled resources, which is usually the fun part because it's really very difficult to identify funding. It's difficult to identify global partnerships. It's difficult to identify the right talent, put together teams, identify markets, create the product market mix, that kind of thing. But it's fairly serendipitous and it's fairly chaotic. It is not linear. And so people who are involved in this kind of endeavor need to have some sort of comfort level with incomplete information, and they have to have a certain sort of risk tolerance to work in this environment. Number three, whether you think your product or service has value is irrelevant. It really doesn't make any difference what you think. The only thing that really matters is what does your customer, user, patient, or stakeholder feel has value, and how do you define and identify that, because that ultimately is the goal of entrepreneurship, to create value. And it's not just creating value, it's creating value through innovation. And without belaboring the issue, the definition of innovation has been bantered around a fair amount. There's a lot of information about disruptive, incremental in the literature. Fundamentally, my view is that innovation is a new way of doing something or creating something new that adds at least 10 times the value of the competitive offering. And the message that I give you is that in most places, the challenge to healthcare is so big that to tinker or to just provide incremental innovation is not going to be helpful. We really need to use a phrase, go big or go home. That's not to say you can't think big and start small, but you have to be able to think big in terms of dealing with systems of innovation, including the non-healthcare systems. And I would just give you the example that, at least in the United States, a fair number of people get their healthcare or use healthcare products and services in non-healthcare environments. They go to retail-based clinics, they go to pharmacies to get shots, they go to health clubs to get their cholesterol measured, and all of that is part of the healthcare ecosystem that we don't usually include or consider when it comes to health innovation. We need to improve that. So the drivers of physician entrepreneurship, as I mentioned, fundamentally have to do with necessity, which I think is in response to economic, demographic, regulatory, legal, and societal changes. It's said that the necessity is the mother of invention. Unfortunately, it is not the mother of innovation, and there's lots of innovative orphans out there as a result. So what's the idea? What's the difference between an idea, an invention, and an innovation? An idea is something that's stuck in your mind and never gets out. And you're in the shower, everybody thinks of 6 or 8 great ideas, and it goes down the drain, and that's the end of it. If you reduce that idea to practice, you make a little sketch, you create a prototype, you put it together with duct tape and styrofoam, then you're talking about an invention. You've reduced an idea to an invention. If you take that invention and then add value to it, now you're talking about an innovation like we just described. There's a qualitative and quantitative component to it. The qualitative component is it's new. The quantitative component is you've added about 10 to 15 times the value of the competitive offering. Now, why 10 or 15 times? Why not 6.3? Why not 25? Because the literature and the research indicates that we do not change from one product to the next unless we perceive at least 5 times the value of the competitive offering as being better, because the switching costs are too high. It's just not worth it. So you really have to see a bigger bang for the buck in order to change your behavior, and if it's going to be innovative, it has to be that much more. So keep in mind defining the value as a quantitative proposition compared to the competitive offering. How much better, different, smarter, cheaper, faster is your idea compared to the competitive offering, whether it's an iPhone app, whether it's a wearable, whether it's a remote sensor, whatever we're talking about. The second issue has to do with human factors, which are the internal drivers. And I would submit to you that part of the reason why innovation ecosystems fail fundamentally has to do with culture. And there are cultures of peoples, there are cultures of governments, there are cultures of countries, there are cultures of universities. And unless you can harness and develop that culture of innovation, it's very, very difficult to move these kinds of programs along. Now, as I said to the group this morning, fundamentally, you guys are the 4th largest economy in the world. You started with next to nothing in 1950, and now you're the 4th largest economy in the world. You're a nation of entrepreneurs. You're a nation of people who work extremely hard and who develop these amazing technologies. So I'm not worried about the entrepreneurial culture. The point has to do with how you organize this and drive innovation from the bottom up with some sort of top-down help. Of course, there are human factors: greed, fear, ego, peer recognition, other things that drive people to do entrepreneurial activities, and in part, those are nature versus nurture. I don't think that you can train, this is just a personal opinion, I don't think that you can train and create entrepreneurs. I'm an ear, nose, and throat surgeon. Part of what I do is train medical students and residents how to do ear, nose, and throat surgery. I can't train someone how to be a surgeon. I can train them how to do surgery. Likewise, I can't train someone how to be an entrepreneur. I can train them in the fundamentals and how to get an idea to market, but I fundamentally can't do that. So rather than try to change the stripes on a tiger, I think you need to think about how do you select individuals who self-select. In other words, they choose, they understand, they know they have what it takes to do this, and then provide them with the support they need to be successful. And finally, the third motivation, as I said, has to do with basic healthcare ethos, which is most of us go into healthcare to try to help people. Now, one way to help people is to physically take care of them day in and day out in the clinic, in the hospital, in the emergency room, in the operating room. And you can do that 40 patients a day for 40 years, and that adds a lot of value, and a lot of patients get helped. Or there are other ways to do it, like pursuing physician entrepreneurship, creating a company, employing 100 people, creating a technology that benefits thousands, and creating regional growth and benefit to the local economy. There are different kinds of physician entrepreneurs. They come in different flavors, and if you remember the definition, pursuit of opportunity, scarce resources, user-defined value, through the deployment of innovation, there are physicians who are employed, who are intrapreneurs. They act like entrepreneurs within their organization. There are private practitioners, and various healthcare systems have more of those and less of those, depending on the structure of the healthcare system. It's fairly common in the United States, although it's dropping. More and more doctors are becoming employees of hospitals and hospital systems. Technopreneurs are people who try to get an idea to market, scale the company, exit, create shareholder value. There are freelancers or consultants who work with other doctors to try to facilitate the development of products and services. And finally, there are physician investors, people who, for one reason or another, have made money and are interested in investing in ideas that they understand. In other words, doctors investing in doctors or in medical technologies. So if you consider these various categories, then for all intents and purposes, the potential market is almost every doctor in the world. But as I said, the addressable market, that is those doctors that have an entrepreneurial mindset, are relatively small, are probably about 1 to 2% of the total doctor population, but the good news is it only takes 1 or 2 to come up with a blockbuster idea. So I think when you're considering, and the question that was posed early this morning at the very beginning of the conference, how does Korea jumpstart and accelerate its health and innovation ecosystem? Part of the answer, and my message is, you have to engage physician entrepreneurs early in the process. If you don't, then you run the risk of failed products. You run the risk of products that are not clinically validated, and digital health is a good example. If you look at the kinds of things that are being promoted, whether it's wearables or sensors or iPhone apps or those kinds of things, very, very few of the 90,000 healthcare apps presently available on Android or iPhone have been clinically validated. In other words, they do what they're supposed to do. So if you create an iPhone app that says, this is going to help diabetics maintain their hemoglobin AC at a relative percentage, and that's going to result in fewer admissions, fewer emergency room visits, less amputations, better control of their diabetes, most of the time those are not clinically validated. So getting physicians involved early on and getting the providers early on, I would encourage you to do. Electronic medical records, with all due respect, I also think is an example of what happens when you don't involve providers early in the production process, early in the new product development process. You wind up with systems that don't help patients, that create physician pushback, and that disrupts workflow. And if you talk to a lot of doctors using electronic medical records, most of the ones that I talk to, and myself, find they're intrusive. The user interfaces are not designed properly, and I feel part of the reason has to do with lack of proper user input and patient input, because these records are being opened and used more and more in patient portals. What does the doctor want? What does the patient want? It's not so much creating something that's just going to generate a bill and generate revenue. So I would encourage you to get those that are interested involved in these product development life cycles much sooner. A second point that I want to make is that there's a difference between biomedical innovation and health innovation. Biomedical innovation fundamentally means drugs, devices, diagnostics, vaccines, biologics, those things that we understand to have long time to market, lots of capital required, very severe and heavy regulatory requirements, intellectual property protection, reimbursement issues, et cetera, et cetera. The usually cited figure is about $1 billion, $1.5 billion in 10 to 15 years to get a drug to market. We can argue about the numbers, but it's a long time and a lot of money. Devices, same sort of thing. Usually it's about $300 to $500 million, 7 to 10 years. Digital health is a different story, and health innovation really comprises digital health, the application of information and communications technologies to improve health, as well as process innovation, platform innovation, systems innovation, and business process innovation. And I've given some examples of what do I mean by that. So now we're talking a lot about transparency. And transparency fundamentally means shifting the doctor-patient power more toward the patient. Old model, I'm the doctor, you're the patient, I tell you what to do and you do it. And usually you don't ask any questions. New model, shared decision making. And there are many, many examples of preference-sensitive conditions where the doctor is talking to the patient and trying to give a dialogue or engage in a dialogue where you and I decide what's in your best interest based on your ethics, values, preferences, etc. You might like radiation therapy, you may have a bias against it. You might have some fears about surgery, you may not. You may decide to do nothing. A typical example is a PSA rising in prostate cancer. And there's lots of different ways to manage that, but you could just fundamentally decide, hey, what, I don't believe in the data, I'm just going to watch and see what happens, and it turns out you'll probably do okay. Small cancers of the thyroid, similar example. There's lots of examples, certain breast cancers, where you really don't need any therapy, but yet we treat a lot of those people. Well, the transparency is shifting, not just in information and data, it's shifting in pricing transparency, and it's shifting in outcomes. So we're seeing a lot of this care delivery model where the basic idea is to improve outcomes, reduce per capita cost, improve the patient experience through transparency of data. Now, how we deal with that is an issue that we all have to deal with and introduces some complicated questions, not the least of which, for example, is who owns the medical record, when does the patient have the right to change the data or redact data, etc. Systems innovation, care delivery, or process innovation has to do with how the care is delivered in an innovative way. And that could be telemedicine, it could be retail-based clinics, it could be EMRs in a van, any way that's different from traditional brick and mortar. And I would say that the big headline has to do with e-care. In other words, healthcare, in my opinion, is about where Barnes & Noble was about 20 years ago, 25 years ago. If you wanted a book, you had to go to brick and mortar Barnes & Noble and buy the book. And if you didn't like the book and you wanted to bring it back, you had to bring it back to the store. Now you can get it online, they have catalogs. You can pretty much interact with them in a combination of brick and mortar and e-commerce. Same thing is happening in healthcare. We're going to see the same migration of brick and mortar care to e-care, but there will have to be a balance. Because like e-commerce, it's very difficult to sustain a business just using an e-commerce model versus a brick and mortar model. Recently, we've witnessed Amazon opening stores. So what used to be a traditional e-commerce model, they've come to realize you have to have both. In addition, I think another thing we have to think about is the high-tech, high-touch issue of technology. So everyone in this room is here because we're debating and trying to come up with the best way to meld health delivery with technology. And once you put those two things together, then you start getting in the way of the doctor-patient relationship. And that's a very important part of medicine, in my opinion. It has to do then with what was referred to many years ago in Megatrends in Nesbitt's book with high-tech, high-touch. And the fact is that the more we introduce technology, the more we run the risk of interfering with the doctor-patient relationship and interfering with the high-touch part. So I believe that there's a place, and people will profit from exploiting the high-touch ramifications of what everyone in this room is trying to do versus introducing just technology. And we all have to deal with that. And the most simple example, in the United States, the average doctor visit is 12 minutes. I don't know what it is in Korea, but it's about 12 minutes, and about 20 to 30% of that time has been found to be spent on a computer. So if you come to see me and you're looking at the back of my neck because I'm typing in a computer, it gets in the way of the doctor-patient relationship. We have to figure out a way, you have to figure out a way, the technologists in the room have to figure out a way to make my life easier, faster, so that I can do what I was trained to do, and that is take care of patients, not be a data entry clerk in a computer. So making a plea that we work together to try to fix some of these things. And finally, business process innovation, which has to do with the back-end business of medicine. How do you verify that a patient is in fact the person they're saying they are? How do you validate that they have the insurance they say they have? How do you process the revenue, particularly when you look at it from a global perspective? Now, Korea has made a name for themselves in medical travel. And I've spent a fair amount of time in medical travel. In fact, I'll show you one of the businesses. And when you're dealing with moving money around the world, and you're dealing with moving data around the world, and you're dealing with moving technology and patients and doctors around the world, then you have to come up with a global ecosystem that affords access to quality care under an affordable price. My contention is we have not done that. And while there's and this is just an aside, while there's a fair amount of medical travel activity going on around the world, I think a lot of it is hype, and I think a lot of it is dangerous. Now, some of it is not, and a lot of it is legitimate, but my concern is we really haven't created a safe global care ecosystem. And if you're looking at trying to create an ecosystem in Seoul, or I'm trying to create a care ecosystem in Colorado, it has to eventually integrate into a global system because we're dealing in a global world. Just look at Ebola. I mean, we deal with patients, capital, technology, doctors, all over the world. So we have to be able to create that system, and whatever system you create in Seoul has to be able to integrate into a global system. Because I'm competing with you. I'm not competing with the guy down the street. I'm competing with Seoul, Manila, Thailand, et cetera, in terms of patient flow. So I would think global, and I would think whatever system you create, it has to be able to be integrated into a global care system. The next point, care has become more and more decentralized. In other words, it gets to this point of transparency. So however you are thinking in terms of designing, developing, deploying, and harvesting innovation, it has to be in the context of patient decentralization. It was alluded to earlier this morning in do-it-yourself medicine. Patients routinely, and I'm sure you do, when you go see the doctor, you come with a stack of stuff from the internet. People are self-diagnosing, people are self-treating, and people are using what I call black market e-care. And again, to me, that is black market e-care means you use systems or platforms, whether they be mobile health or telecom, that are not secure, that are not, in our terms, HIPAA compliant, and that expose the data to risk. So people are using FaceTime. People are using Google Hangouts. People are using various kinds of video conferencing platforms that were not designed to transmit healthcare data. It's the tail wagging the dog. It's a video conferencing system that's being adapted to the healthcare system instead of creating a digital health complete solution. So what am I saying? I'm saying that, in my opinion, the technology industry has dropped the ball. I'm sorry. I do not think today there is a comprehensive solution in digital health, particularly in telemedicine, where there's an electronic medical record, revenue cycle management, scheduling back office process innovation that fits into a global e-care system that I can use securely. So the challenge is for us to work together and come up with something like that, and to get paid for it, and to generate the appropriate documentation to satisfy certain certification and regulatory requirements. So I think we have a lot of work to do in terms of coming up with a complete e-care solution. I haven't found it yet, and my concern is we're just simply bolting on smokestacks on top of each other, and we're not adding the value that we should. Another point, in the world of digital health, in the world of digitization, where are these people going to come from that are going to do this? I mean, I can tell you that digital health is not an important or any part of a medical education curriculum in most medical schools. And unless we start paying attention to training doctors in digital health, and I just don't mean go to a hospital and learn how to use the electronic medical record. I mean, How do we deliver and train people to use e-care in the clinical setting? We also have a shortage of data scientists, particularly those that are trained in healthcare. Who's going to use all this data? Who's going to analyze all this data? Who do you expect to use this data? Don't expect me to use it. I mean, if you go out and send me 24 hours worth of wearable stuff, there is no way in God's creation I'm going to be able to do anything with that. I need you to reduce big data to small, actionable information. Don't give me big data. I'm going to choke if I hear that one more time. I can't do anything with that. I need to be able to get actionable information that I can treat the patient standing in front of me. We need people who are trained to do that. I also think it's unreasonable to expect people to be the interface between the data and the patient. I think machine learning, I think artificial intelligence, I think Watson, I think technology will massage the data and provide the information, because I fundamentally believe that computers are much better decision makers than I am. That said, as a doctor, I do things other than make decisions. The most important thing is I'm a person, and it gets to this high-tech, high-touch thing. So my job is to provide the compassion, the empathy, the understanding. The computer, I actually think, will make a better decision. The fact of the matter is that about 6 to 8% of medical decisions are wrong across the world in diagnoses. There's some that are more prominent than others. I think that number can be reduced substantially by smart artificial intelligence, machine learning, that kind of thing. But the point is, we need to do a better job of educating people about what's necessary in digital health, and there's some references and links here about some of the things that we've attempted to do in Colorado. And just to mention it, we have created a bioentrepreneurship and education program at the graduate level for graduate students, for health professionals, for engineers, for those people who are interested in getting an idea to market. They're very solution-focused. They are not problem-focused. We're trying to migrate that to an entrepreneurial mindset so that they are problem seekers first, not problem solvers. There's an international consortium of people that are trying to do this around the world, and if you're interested, I can give you more information. But the message that I'm trying to give you is, look at how you are training your digital health workforce in Korea, who are health professionals. And if you do not have that on your radar screen, I'd suggest you need to give it some serious thought and do something. There's lots of places around the world that have experimented with this. There's a lot of different programs. No one size fits all, but it's something that I think you need to do. Finally, let me finish. The Society of Physician Entrepreneurs is a global biomedical nonprofit innovation network. We have chapters around the world. Part of the reason that I was pleased to accept this invitation was to encourage you to create a SoPE Seoul chapter. And it's a way to get people together to create the seeds of an innovation network to drive innovation forward in collaboration with entrepreneurs, service providers, investors, hospital providers, industry, etc. Many, many barriers to physician entrepreneurship, which we unfortunately don't have time to go through. The bottom line is that physicians are eager to drive innovation and add value to patients and are doing it increasingly around the world, some more so in some innovation ecosystems, some in other places. The primary megatrends of healthcare are modernization, internationalization, resource constraints, demographics, mobile communications, and new models of transparency, and those are the things you need to consider in your value proposition. There are many, many stakeholders in this game, and if you try to do this independent of those other stakeholders, it will not succeed. Those innovation systems that work are those that are integrated, that have very tight internal and external robust communications networks, and that drive information on a fairly regular basis. Thank you for your attention, and I hope to collaborate sometime in the future.
Thank you, Professor Meyers. Now we will have time for Q&A. 알렌 메이어스 교수님 감사합니다. 잠시 질의응답 시간을 갖도록 하겠습니다. 교수님께 질문 있으신 분은 손을 들어주시면 저희 스태프가 마이크를 전달해 드리겠습니다.
Oh, good. Okay, so now I can understand if someone speaks in Korean.
질문이 있으신 분께서는 손을 들어주시기 바랍니다.
I must have said something that annoyed someone.
질문 없으신가요? 저기 뒤에 한 분 계신 것 같은데요.
예, 알렌 메이어스 교수님 발표 잘 들었습니다. 그 발표 강의 중에 그 의사의 1%만 기업가가 될 수 있다라고 얘기를 하셨는데 그 이유가 좀 궁금하고요. 의사 창업이 왜 늘고 있는지에 대해서도 좀 설명을 부탁드립니다. 지금 특히 SoPE 같은 경우에는 해마다 그 의사들이 가입하고 있는 숫자가 어떻게 되고 있나요?
Okay, thank you for the question. So I heard three questions. One is, why do I think that only 1% of physicians are physician entrepreneurs? First of all, let me ask a question. How many in this audience are doctors? Okay, so I'm seeing about 10% ballpark. Every time I go to a conference like this, I get the same response. And I would tell you that if you make progress, and I hope you do, and I'd be glad to help you do it, if you make progress in building this innovation ecosystem, 30 to 40% of the people next year will be doctors sitting in the room. You can't do this in isolation. Most of you are sitting in the room are technologists or industry or venture people. You have to have the health professionals in this room with you to collaborate. That aside, why do I think 1%? Because that's the way medical schools pick doctors. You don't get picked to go to medical school in Korea or in Colorado because you are creative, because you are innovative, because you are entrepreneurial. You get picked because you're good at memorizing stuff. And you've spent a lot of money practicing for the test, right? So that's why I got picked. I'm no genius. So it has to change. And this trickles down to the medical education establishment. Until your medical school admissions committees consider innovation and entrepreneurship and recruit for innovation, it's going to be the blind leading the blind. We're going to be back here next year saying the same stuff. So that has to change. So why only 1%? Because that's how doctors get picked. If we picked people from outside of science, technology, engineering, and math, we'd have a lot more creative healthcare workforce. And that's why I'm saying I don't think healthcare can be fixed from inside. It has to be, innovation has to come from the outside. Most of you in this room have solved most of the problems confronting healthcare. The technologists in the room have solved, to some extent, data security and transformation. As an example, when I go to the operating room to start operating at 7:30 in the morning and I can't start till 8 o'clock, I would rather have an air traffic controller from Korean Airlines running the operating room than a nurse. When people are backed up in the waiting room, why do we call it a waiting room? There are people who understand demand management, airlines, McDonald's. When it comes to communicating health information, Verizon, AT&T, Samsung. There are other industries that have solved these problems, and they need to be part of healthcare. So my pitch, go out and find those people who do not, if you want to see innovation, do not find it at a medical meeting. It's not going to happen. You have to go other places. Okay, so number two, why do I think that the Society of Physician Entrepreneurs is growing? A couple of reasons. One, doctors are angry and they want to be re-engaged and they want to participate in the innovation process. They're tired of being marginalized. Anywhere in the world, not just the United States, it's not just an angry Yankee who's giving you this information. There are people around the world, doctors everywhere I go, I don't care whether it's in sub-Saharan Africa, Lisbon, Seoul, I don't care. They're angry. Stop marginalizing us. Engage us. We're smart people. We can help you make a lot of money. Number two, I think that the necessity for innovation is become so prominent that more and more, as I said, people just want to get engaged and they see it as another way to join. They see it as another way to get involved and to help patients. And they're motivated. I mean, we want to do this. We want to help people. But we don't want to do it necessarily seeing 40 a day, 100 a day in some places for 40 years. Different mentality. So I hope that answers the question.
Thank you, Dr. Meyers. 시간 관계상 이상으로 두 번째 기조연설과 Q&A 세션을 마치도록 하겠습니다. 좋은 강연해 주신 메이어스 교수님께 다시 한번 큰 박수 부탁드립니다.